In this series, we've discussed some recent findings that have led to dramatic major changes in our understanding of substance abuse disorders. We've seen how an understanding of the reinforcement model, genetics, and the neurobiology of addiction have led to successful new treatment methods while also providing a scientific basis for some traditional treatment approaches. In this, the fifth installment of this series on drug abuse, we're going to focus on one more aspect of substance abuse treatment, the high rate of concurrent psychiatric problems experienced by drug abusers. Although our progress in understanding substance abuse disorders has yielded some great successes, ironically, it may have also clouded some of the original vision. The medical community has long considered addiction as a serious psychiatric disorder. Like schizophrenia, depression, anxiety, and bipolar disorder, substance abuse also has a genetic component that causes changes in the chemistry of the brain. However, the rise of specialized substance abuse treatment programs has in part separated substance abuse from other psychiatric disorders in the minds of many treatment providers. Although these specialized treatment programs have led to improvements in the treatment of drug addictions, they have also contributed to a gap between substance abuse treatment and treatment of other mental health disorders. This gap is a serious issue because substance abuse and other psychiatric disorders often occur together. Unfortunately, approximately 1 in every 3 patients receiving treatment for substance abuse also suffers from a serious psychiatric disorder. And conversely, about 1 in 3 patients with a psychiatric disorder also experiences problems with drugs. Providing diagnosis and treatment for these patients is a significant challenge. For instance, are they abusing cocaine because they're depressed, or are they depressed because of their cocaine use? Or could it be that they are both depressed and a cocaine abuser? Even for a professional, these questions can be daunting to say the least. But for the patient, these concerns can lead to a big red stop sign on an already bumpy road to recovery. Coming up, we're going to learn more about treatments for psychiatric disorders and how they relate to substance abuse. Research has shown that drug abusers are significantly more likely to suffer from a serious psychiatric disorder than the rest of the population. These disorders include depression, anxiety, phobias, bipolar disorder, and schizophrenia, and they affect about 1/3 of all drug abusers. Although it's unclear why substance abusers are more prone to these psychiatric disorders, studies show that bipolar disorder and schizophrenia, as well as some forms of depression, have important genetic components which, much like substance abuse, impact the chemistry of the brain. To make significant gains in their treatment, many drug abusers will need help with both their substance abuse and their psychiatric disorder. For an example, research has shown that if a cocaine abuser who is also suffering from depression does not receive treatment for their depression, they are significantly more likely to relapse to heavy cocaine use. The same is true for psychiatric patients who also have a history of problems with drugs. Drug abuse can slow progress in the treatment of their psychiatric disorder, as some abused drugs can reduce the effectiveness of some prescribed medications, resulting in more frequent and longer hospitalizations. Unfortunately, treatment providers for mental health care and treatment providers for substance abuse each tend to focus on their particular areas of specialization. Therefore, it's not uncommon for mental health care professionals concentrating on psychiatric disorders to pay inadequate attention to the diagnosis of drug abuse. Similarly, substance abuse treatment providers focused on drug-related behaviors may not identify psychiatric problems. Treatment providers in each field have their own unique terms for these multifaceted patients. Substance abuse treatment programs most commonly refer to them as dual diagnosis patients. The correct classification of dual diagnosis patients presents a considerable challenge for even the most skilled practitioners. For example, chronic methamphetamine abuse can cause symptoms that are very similar to those caused by other psychiatric disorders. Therefore, it can be a challenge to differentiate symptoms resulting from chronic heavy drug use from those that are not caused by the patient's drug use. Because of this similarity, most practitioners are reluctant to diagnose a substance abuser with another disorder until they have been drug-free for at least 4 to 6 weeks. Abstinence can further confuse things. Because abstaining from drugs can alleviate some of a drug abuser's psychiatric symptoms, some practitioners have come to think of abstinence as a type of dual remedy. But unfortunately, this failure to correctly identify and treat dual diagnosis patients can quickly lead to further and far more severe consequences. We've learned that although drug abuse has long been considered a psychiatric disorder, the rise in specialized addiction treatment programs has helped to separate it from other mental health problems. This has led to a widening gap between substance abuse and mental health treatment, as specialization has left treatment providers unprepared to deal with the large number of their patients who are suffering from both substance abuse and psychiatric disorders. We've also learned that dual diagnosis patients present considerable challenges for treatment providers, as their symptoms are often difficult to correctly diagnose. And finally, we learned that many dual diagnosis patients are inadequately evaluated, and therefore many of their serious symptoms remain untreated. Like other psychiatric disorders, we know that substance abuse has a genetic component that changes the chemistry in the brain. Yet, unlike other psychiatric disorders, a different philosophy underlies the treatment of substance abuse. For the treatment of most psychiatric disorders, the use of medications is commonplace. Prescription drugs like lithium, Prozac, and Valium are household names. But as we've seen earlier in this series, the use of medications to treat drug abuse is not widely accepted within the treatment community. Although medications are widely used for the treatment of psychiatric disorders, the concept of using prescription drugs to treat addictive behaviors is, for some people, a controversial notion. In other programs, we saw how the drug naltrexone may help reduce cravings in alcoholics by limiting the amount of dopamine released into the reward pathways of the brain, and how new treatments are being developed for addiction to other drugs such as cocaine and heroin. Now, let's take a look at some of the medications prescribed for 4 serious psychiatric disorders: schizophrenia, depression, anxiety, and bipolar disorder, to learn how they may impact the treatment of substance abuse. Most medications for psychiatric conditions work by affecting the levels of several key neurotransmitters. Drug treatments for schizophrenia have changed and improved in recent years. In the past, the most effective treatments were medications like haloperidol. Haloperidol and related drugs worked by blocking dopamine receptor sites in several areas of the brain. Drugs that work by blocking neurotransmitters are called antagonists. We know that cocaine, amphetamine, and all other drugs of abuse create their feelings of pleasure by increasing the effects of dopamine in the reward pathways. However, dopamine antagonist drugs used for treating schizophrenia have little or no effect on drug use. To explain why, we're going to use a lock and key analogy with the neurotransmitter depicted as a key and the receptor site shown as a lock. While our brain has only one type of dopamine, shown here by several identical keys, it has many slightly different types of dopamine receptors, shown here by the numerous locks, in the same way that a master key can open several different but similar locks. Clustered together, the different types of dopamine receptor sites are associated with different types of brain activities, ranging from how we think to how our bodies move. Like a master key that can open all of the different types of dopamine receptor locks, dopamine affects a wide range of behaviors. This is where drugs like haloperidol come into play, but instead of acting just like the dopamine master key, they are specific to only one lock, that is, to just one type of dopamine receptor. Haloperidol and other similar drugs are a good fit for the dopamine receptors that control our perceptions and interpretations of reality. But these medications are not a good fit for the receptors associated with feelings of pleasure, which is why these drugs do not affect the euphoria derived from taking drugs of abuse. While dopamine antagonist drugs have been a powerful treatment for schizophrenia, it has recently become clear that dopamine is not the only neurotransmitter involved with this disorder. Serotonin, a neurotransmitter that helps control our moods, is also closely associated with schizophrenia. Some of the newer antagonist-type medications, such as clozapine and risperidone, work by blocking both dopamine and serotonin. There are two neurotransmitters that play an important role in depression: serotonin, which helps to control moods, and norepinephrine, which impacts our ability to concentrate. The most prevailing theory as to why some people develop depression is that their serotonin or norepinephrine neurons are not functioning properly. To understand this, and to gain an understanding of how antidepressant medications work effectively in treating depression, we must first review how neurons work. When a neuron fires, it releases neurotransmitters into the synapse. These neurotransmitters bind to receptors on neighboring neurons, and in doing so transmit important signals which tell the neurons to increase or decrease their activities. Once the message is delivered, the neurotransmitters are released from their receptors. These neurotransmitter molecules must now be quickly cleared out of the synapse, or they will continue to bind to receptors over and over. One of the ways the brain clears neurotransmitters from the synapse is through a process called reuptake. During reuptake, the neurotransmitter molecules are recycled and taken back up into the firing neuron, where they can be made ready to be used again. Almost all antidepressant medications work by blocking this reuptake process. Most antidepressants, such as fluoxetine and sertraline, very specifically block only the reuptake of serotonin. Other antidepressants, especially the tricyclic antidepressants such as imipramine and amitriptyline, block reuptake for serotonin and norepinephrine. Coincidentally, some studies have found that sertraline and fluoxetine may help to reduce a drug abuser's motivation to take some drugs. Normally, blocking the reuptake process would cause the brain to malfunction, but a depressed brain is not a normal brain. Blocking reuptake forces the neurotransmitter to stay out in the synaptic cleft, which causes additional messages to be sent to neighboring neurons. For the receiving neuron, being bombarded by all of these extra messages is just like having the volume on the radio turned too high. The neuron's response to all of these extra messages is to turn the volume down by reducing the number of receptors for the neurotransmitter. This is a common process called downregulation. Downregulation is part of the brain's way of maintaining a normal level of activity. So through a series of chemical events, antidepressants work by ultimately causing downregulation. That is, a decrease in activity in the brain pathways which control our moods. People suffering with anxiety disorders feel very high levels of stress. And as we know, one of the ways people relieve their stress is to turn to sedative and tranquilizer drugs like barbiturates and benzodiazepines. Among the most commonly prescribed benzodiazepines are diazepam, alprazolam, and clonazepam. As we saw earlier in this series, the primary effect of these types of drugs on the brain is to cause ion channels controlled by the neurotransmitter GABA to open more and allow more negative ions into neurons throughout the brain. Negative ions make neurons less likely to fire, which decreases certain brain activities, which reduces how stressed we feel, while at the same time increasing our feelings of relaxation. That's how these drugs relieve stress, and it's also why these drugs can be abused. So, just like alcohol, benzodiazepines and barbiturates make neurons less likely to fire by affecting the activity of GABA channels. And as with alcohol, the result is the same: relief of stress and more relaxation. Bipolar personality disorder is a serious psychiatric problem commonly associated with drug abuse, especially abuse of stimulants. Treatment for bipolar disorder often involves lithium-based medications, and while they have been studied extensively, it is still not entirely clear how these medications work. Most current thinking on how lithium works suggests that it changes the functioning of the brain by affecting ion levels. One way that it may do this is by stabilizing neural membranes, which in turn affects the function of ion channels. There is also some research suggesting that lithium modifies serotonin levels, while other studies suggest that in some way it makes overactive nerve cells less likely to fire. We've learned that some of the most severe psychiatric disorders, including schizophrenia, depression, anxiety, and bipolar disorder, have a genetic component that changes the chemistry of the brain. And for psychiatric disorders, the use of medications is commonplace. But for substance abuse disorders, the use of prescription drugs is still an evolving practice. And finally, we've learned that medications used to treat psychiatric disorders work by affecting the levels of several key neurotransmitters in the brain. Although we've learned more about dual diagnosis patients and the medications that are used for certain psychiatric disorders, there are still fundamental questions to be answered. For example, which disorder happened first, the psychiatric problem or the drug abuse? And does it even matter? To answer these questions, let's take a closer look at the relationship between substance abuse and other psychiatric disorders, and why certain treatment providers struggle with prescription medications as a treatment option. For many dual diagnosis patients, the nature of the relationship between their psychiatric disorder and their substance abuse disorder is unclear, and it is important to understand that there are many instances where these disorders are not related. These individuals just happen to suffer from two severe problems at the same time. But it is also clear that one disorder affects the other, as chronic drug use can cause or worsen psychiatric symptoms and lengthen psychiatric hospitalizations, while worsening psychiatric symptoms can make abstinence an even greater challenge. While there are no definitive answers to explain the relationship between psychiatric disorders and substance abuse disorders, there are several theories. One of the more familiar theories explaining why some people with psychiatric disorders also abuse drugs is that they are trying to self-medicate their psychiatric symptoms by taking drugs to feel better. But unfortunately, while drug use may have begun as self-medication, for many individuals their drug-taking behavior takes on a life of its own. For these dual diagnosis psychiatric patients, research shows that treatment with the appropriate medications may greatly reduce the severity of their psychiatric symptoms, but may have little or no effect on their drug use. Which is why for individuals who began using drugs to self-medicate, their psychiatric problems are probably best viewed as a risk factor for the development of a substance abuse disorder. As we have seen, some drug abusers who develop psychiatric problems may see a remission in their symptoms soon after they quit taking drugs. But other drug abusers may not be so lucky. For them, their chronic drug abuse may have led to psychiatric disorders that linger long after they become abstinent. Unfortunately for these individuals, they may have been genetically predisposed to a particular psychiatric disorder that was triggered by their drug use. A thorough psychosocial history, paying particularly close attention to the timing and onset of both the psychiatric symptoms and the progression of their drug use, is very important. But regardless of their etiology, dual diagnosis patients with their complex and intertwining symptoms present a significant case management challenge, particularly if they require medication. For a variety of reasons, many physicians are hesitant to use medications to treat substance abusers with concurrent psychiatric disorders. One common reason for their reluctance is the potential for abuse. This concern stems from the fact that many drug abusers have long histories of using drugs to modify their moods. While it is true that some psychiatric medications, particularly those used to treat anxiety, can be abused, most psychiatric medications have little or no abuse potential. Another concern is the potential for toxic drug interactions. Some treatment providers are concerned that the use of medications during a period of heavy drug use may cause toxic interactions between the abused drug and the medication. Although this could happen with some medications, it is usually possible to avoid toxic interactions and prescribe medications that are safe, even in combination with drugs such as cocaine, methamphetamine, or heroin. However, some caution is needed with the use of methadone or LAM for the treatment of heroin addiction. Both of these medications can interact with tranquilizers, some antidepressants, alcohol, and other drugs. For most patients, however, the benefits from using these medications far outweigh their possible side effects. Treatment providers are also concerned with medication non-compliance. If a patient has relapsed, he or she may start taking their medication intermittently. With some medications, intermittent use can sometimes be worse than not taking the medication at all. Ultimately, it probably doesn't matter which symptoms came first, those of substance abuse or those of another psychiatric disorder. What really matters is that both problems receive careful evaluation and treatment. Otherwise, dual diagnosis psychiatric patients will continue to abuse drugs because the medications they receive for their psychiatric problems may have little effect on their drug use. And dual diagnosis substance abuse patients in treatment will not be able to focus or abstain long enough to gain the coping skills that they are being taught. We've learned that while there are several theories concerning the relationship between concurrent substance abuse disorders and other psychiatric disorders, there is no definitive answer. However, we do know that treatments for psychiatric disorders often have little impact on drug use. Although treatments for substance abuse appear initially to help concurrent psychiatric disorders by promoting abstinence, if left untreated, the psychiatric disorders can lead to a relapse. We've also learned that although there are several reasons why some treatment providers are reluctant to prescribe medications to treat dual diagnosis patients, research has shown most of these concerns to be unfounded. Finally, and most importantly, we've learned that the best treatment for dual diagnosis patients lies in the careful evaluation and treatment of all disorders. For treatment providers, this may mean a need for more training to gain a more comprehensive understanding of psychiatric disorders, including substance abuse. And for the 1/3 of their patients with a dual diagnosis, recognition of both problems makes for a smoother ride down the long and sometimes confusing road to recovery.